Kia ora. Welcome everybody to this webinar in relationship to the supported first year of practice. I'll just go through the attendees in terms of those who are presenting or involved in the sharing of information. So, ko Emma Hickson Tokuingoa, and I work in Te Whatu Ora as a clinical advisor for planning, funding and outcomes, and for our Chief Nurse Nadine Grey for nursing. And I'll pass on to my colleague Liz Manning.
Kia ora, ko Liz Manning toku ingoa. I'm the Strategic Workforce Lead for Nursing at Te Whatu Ora Health New Zealand, and work very closely with Emma Hickson, who you've just met, Nadine Grey, and of course Bex, who's next. Bex.
Kia ora koutou, my name's Bex Warder. I am the engagement lead for the what we call the PCTAP 400, because its actual title is quite the mouthful, but essentially we provide the funding for graduates entering into the community.
Kia ora, I'm Agustilia Rodrigues, and I'm the Learning and Development Clinical Manager at Heritage Lifecare. Really glad to be here. Thank you.
All right, so look, Liz and I will go through a couple of slides just to re-familiarize everybody with the changes that have happened from a national level in regards to the guidance for that supported first year of practice. And we'll then pass on to Agustilia to go through some of her experiences of said supported first year RN graduates. So there's a bit of background related to the developments in the more recent history. We have in Aotearoa a challenge to have enough jobs for our graduate RNs. We want to obviously support them optimally, but additionally we want to make sure that we make it as doable as possible for employers to employ graduate RNs. And so we, in essence, wanted to review the specifications that Health New Zealand had inherited from its previous entities in terms of, as it was called, their nurse entry to practice. There were specifications which were adopted nationally through the hospital and the specialist system, but also through our primary and community spaces. And so as part of our drive to see what we could support in terms of increasing the opportunities for graduates to get their first job, we reviewed those nurse entry to practice specifications. In so doing, we actually found there was quite a lot of changes that were relevant to be made, and we'll go through those changes in a little while. But the focus for us was definitely on increasing graduates to get employment, not only in Health New Zealand, but also in other places like primary and community. And in early 25, in fact, it was at the very end of 2024, an ACE 200 process was set up, which was the beginning of the incentivizing of primary and community employers to take graduate RNs. And that ran from January 25 through to May, and then it was superseded by what we are calling the PCTAP, or Primary Care Tactical Action Plan, which is a national piece of work which was aiming to employ up to 400 of these graduate RNs between May 25 and end of June 2026. So those two processes, as I said, offer some incentive finances to employers, and potentially you might well have been involved in that already. But our aim for all of this is to build the employment opportunities, and especially focusing on primary and community as a place where graduate RNs can get their first job. Next slide, please. So that PCTAP, the Primary Care Tactical Action Plan, had more than just incentivising of graduate RNs. It's a direction shown of Health New Zealand's investment into the registered nurse workforces. So it starts with the graduates, 400 graduates being incentivised through their employers to get their first job. And as you can see there, there's a differential between urban and rural incentive dollar. The second stream of investment is to support postgraduate education for up to 120 primary and community registered nurses every year. And that has been particularly successful with well over 120 potential applicants and recipients of that scholarship. Very much the focus of that is to support the registered nurse workforce to focus on extending their scope and capability and doing postgraduate study en route to qualifications like the RN prescribing diploma. And add into that the fact that this primary care tactical action plan includes the supporting of 120 nurse practitioner training places, and this is an every year from next year. And there are more places for our hospital NP candidates, but 120 places for the primary and community sector. So those three streams of investment are an indication of how Health New Zealand is absolutely focusing on the workforce, the nursing workforce in primary and community setting, which includes aged and residential care. The next slide is just an illustration of the work that we did when we were benchmarking. Oh, it shows you, first of all, the graduate numbers that are coming and being available. So these are New Zealand trained graduate RNs, and you can see the year-on-year numbers who are qualifying. And as you can see, the numbers are not getting less in general. And what we have found over the last 2 years at least, that the turnover of workforce has dramatically reduced, and we find that we have more RNs than there are available jobs. So this is why we are really driven to look at every and any opportunity that would make it easier to employ these graduate RNs wherever across our whole health system. So what we did, we benchmarked what our specifications related to that first year of practice were doing in New Zealand compared to Australia. And as you can see, this was the old NETP, nurse entry to practice specifications, where the study day allocation and the clinical load sharing were markedly higher in New Zealand than overseas. So what we did when we reviewed those specifications and made them the new supported first year of practice guidelines, we brought the numbers for us much more in line with our overseas colleagues. The other thing we do is, as we developed the new supported first year of practice guidance or specifications for our hospital colleagues, we looked at the language that we used. And our next slide, which Liz will talk to, just describes some of those changed language emphasis. Over to you, Liz.
Yeah, thank you. So the first thing that we have made a point of doing throughout this process is to ensure that we are consistently using the scope descriptors to describe which nurses we're talking about. So we've got 3 scopes in nursing: enrolled nurse, registered nurse, and nurse practitioner, and those scopes are all quite different. So it's really important when we're referring to supported first year of practice, whether we're referring to enrolled nurses or registered nurses, quite different. So it just supports there is expertise and diversity in nursing, and it's really important that we understand the scopes and who we're talking about. The other thing that we've done, as you've realised, is changed the title of the first year of practice from NETP, as it was, into supported first year of practice. NETP was built and built over 20 years, and we felt it was quite ready for review. And also, it was causing a degree of stress for graduate registered nurses who, towards the end of their undergraduate program and as they register as graduate RNs, were very, very bound up by needing to be part of a NETP program as their next step. And because NETP programs were not widely used outside of Health New Zealand, we felt it was really important to level the playing field and ensure that there is the same specifications across Health New Zealand, and also guidance for supported first year of practice in primary healthcare and community settings. So it just makes things a little more fair, and it makes sure that graduates get access to preceptorship and an education allocation once they get a job in those spaces. NETP was also quite a fixed construct. So it was a program on which we ran in Health New Zealand twice a year with the big, it was usually June and December. We'd start with NETP programs and it would be a big cohort coming through. So we've tried to move away from that and look at employment year round and adding a little more agility and flexibility so that graduates can plug into supported first year of practice rather than having to join a program at a specific time. We've moved away from the concept of new grad or a NETP because actually these are regulated health professionals. They're competent. They have been, they've passed state. They've got an annual practicing certificate, and we wanted to make sure we could lift them up into practice rather than othering them into something that was still linked to the student role that they'd had. We want to lift them into practice and build their confidence over that period of time. So it's just about removing that reductionist language and referring to them as registered nurses. It's really important that they feel and can practice as registered nurses straight away. As I intimated earlier, we talked about moving from the concept of a program. Supported first year of practice is a flexible year-round education and professional support package, and the transition happens over the period of time that the graduate RN requires it. We've also moved from the concept of supernumerary. In nursing, we've used the word supernumerary for many, many years, and we're moving to clinical load sharing. We would like graduate registered nurses to be, rather than walking alongside, working alongside. So as soon as they get into the clinical practice space, we want them to be working together with their preceptor in those early stages of SFYP to actually get clinical experience and experiential learning. We're also moving away from the reference to study days and supernumerary weeks. So we're moving to hours because we're using a lot more online learning. We're using digital communities of practice, and we're moving to clinical load sharing across a period of time. Hours work much better when you're talking about a transition that's going to take some months to get through. So it flexes across time and it suits online learning really well. And for 2025, we felt it was important. Next slide, please.
So this slide describes the actual developments and changes that the old NETP specifications have grown into to become the SFYP specifications and guidance for our primary and community sector. So the FTE, it was always at 0.6 in the old specifications, but we've just brought that a bit up higher, more profiled. So employing graduate RNs at 0.6 to 1 FTE is what we think will help making that more flexible, will help that more employers will be able to employ more graduates. They might not have the resources for 1 FTE, but they might have resources for a 0.6 position. And some people would say that 0.6 isn't enough, but it's better than no position at all. So we are trying to be as pragmatic as we can on this and say, if you got employment at 0.6, potentially be able to do extra additional hours, and that will lead you to your, higher FTE job in your future, rather than sitting languishing without a role for months, which is exactly what we don't want. So as it says there, our imperative, our goal is to support as many graduates into jobs as is possible. As Liz said, the clinical load sharing terminology, we're talking about 80 hours to 120 hours over as much time as that takes. So potentially much earlier in the first 3 months, they will be doing contributing to the actual work of the registered nurse as a registered nurse, and they will work alongside and be supportive of the team rather than being the supernumerary as was. Again, this could be much more attractive to employers to know that their graduate RNs and the teams that they work in can, hope for much earlier contribution to the actual clinical load and work sharing situation. Having said that, the clinical load sharing requirement of graduate registered nurses is a flexible thing, and some won't require that much, but others might require more. So it's hugely variable and dependent on their previous experiences. And if they've had their transition experience from their undergraduate placement in the place of employment of that first job, it would be much less. But if they haven't, it could be more. So the key part of these specifications or guidance is flexibility, that the individual is supported in a flexible manner, and we maintain their and everybody else's safety. The study, the hours, we're saying 80 hours, including all the mandatory trainings, which there is a bit of, would be adequate for that first year. Study throughout nurses, RNs career is every year. And we feel, and the evidence supported the fact that they need to have as much clinical learning time as is possible. And additionally, those 80 hours potentially might not be classroom hours. They could be online learning, so that, again, there's that greater flexibility that both the workplace, the employer, and the graduate RN can utilize. Less time out of clinical environment where there's a lot of learning to be had, and more time in that flexible approach to the study that has to be had to gain some of the additional clinical skills specific to the area of practice. And that's one additional thing we'd say, is that every clinical area will have their own individual approach to this and their own specific needs related to the population and the clinical space that it is. Postgraduate study, that has happened historically in the first year, but we are saying it really should be out of the first year. The general movement has been in that direction, but this is supporting postgraduate study to happen outside or after that first year. The PDRP requirement that has been historically with the NetP version of the supported first year, we're saying that PDRP can happen after the first year, potentially something that could happen, as soon as that first year is done. And the final point on this slide is that we will be looking for some really good reporting, especially from our hospital and specialist system, in relationship to these changes, so that we can understand how well the application of the new specifications has gone. But we will be, and we are planning, a fairly robust evaluation of the differences and the changes, so that we can say, this is right or whether we actually need to make changes again. So both reporting and evaluation are going to be key parts of 2026 and onwards, I suspect, because almost certainly there will be some further changes that need to be made. I'll pass back to Liz for the next slide. Oh, you're on mute. Sorry, Liz.
I've indicated some of these things already, but I'll just cover them again. So the graduate registered nurse transition, we've got the same specifications across the sector. In Health New Zealand, they are specifications, elsewhere they're guidance. One of the things that was really important in our decision making around this was that senior nurses in other parts of the sector were leading what they knew to be what was required for transition to practice in their settings. So you'll see as we look at the model moving on, that the education component is really dependent on practice setting and very, very much led by nurse leaders in those places. Year-round graduate employment, and just an acknowledgement that supported first year of practice, we're really saying a one size fits all approach, it doesn't work. We've got a very diverse nursing workforce, we've got a very diverse healthcare ecosystem, and we need something a lot more flexible to fit for 2025 onwards. Part of our work in this has been to really reinforce that a key component of supported first year of practice is communication between preceptors, nurse leaders, and graduate registered nurses. And we have developed practice transition plans, which can be used if people want to use them. They can be used on regular conversations to see how practice is developing, to set goals where required, and to just keep an eye on any issues that the graduate might have through their practice in that first year. So again, it's about communication. That's the key. So next slide, please. So this just overviews the idea of supported first year of practice. As you can see, it's really dominated by preceptorship, regular check-ins and communication, clinical load sharing, and professional support for career conversations. The graduate registered nurse is central to this process, so it's really important that that communication and those relationships are established. Rather than taking them out of the clinical setting, we're suggesting that they're learning in the clinical setting more, and that's around socialization to working in that clinical team and becoming part of that clinical team. That's a really important part of that first year. The other requirements, of course, of that graduate year, as I've indicated, are practice area specific and will be orientation, mandatory training, education, and clinical practice and skills acquisition. But those will be dependent on the practice setting. So it depends what the nurse leaders in those practice settings believe needs to happen in that first year. And there may be a variety of things wide variety of things that could be covered in that first year. And we don't suggest what those things need to be. It will be different for every practice setting. Next slide, please. So supported first year of practice comes in 3 phases. And this is an internationally researched evidence-based model from Canada, actually, by Professor Dusha. And it's split into 3 parts, as I've said. Months 1 to 3, we call the doing months. And this is the most intensive part of the supported first year of practice. This is where the clinical load sharing really kicks in and is most important as graduate RNs develop their task mastery and skill development. A named primary preceptor is vital, and we do require that when we go through eligibility criteria for employers. You really need to have a bare minimum of 1 preceptor, but more if possible. And we've got a short online preceptorship course for organisations that want to build their preceptor capacity and capability. We have already talked about monthly check-ins, regular assessments, and individual transition plans and progress, and flexible education across the year to suit flexible start dates. So that's the most intensive of the three sections. Can I get the next slide, please? Months 4 to 6 is being, and this is where registered nurses start to know what they don't know. So it can be a difficult time to get through. So we do need to continue with access to preceptors, with access to clinical coach or nurse leader support during this time to increase that independence and the confidence over that period of time. Educational release will obviously continue as required, depending what needs to be covered off. And what's really, really important is that progress monitoring. So continuing those conversations and individual development and formal check-ins. The formal check-in really with maybe the manager, nurse leader at 6 months to just see how things are going. Next slide, please. Months 7 to 12 is knowing. So this is the final stage of transition. So there is still a relationship very much with the preceptor and or mentor. Monthly check-ins at least as graduate RNs develop their professional identity. Performance monitoring, making sure that goals are still being met and that things are going as they need to across that period of time. And this is where career conversations will start to happen. Emma indicated earlier that we're not requiring PDRP. One of the things that we've been promoting for the end of the graduate year is that graduate registered nurses at that point, registered nurses actually undertake preceptorship training. So they can do the online course and become preceptors themselves because they make fabulous preceptors. So we're encouraging people to do that and build that preceptor capability. Next slide, please.
Shall I do this one, Liz? So this one is just a bit more information on community prescribing. It's something that your colleagues might already be deeply involved in, but we are very excited to say that we're going to look at the RN prescribing and community health programs nationally, and a review process will help us understand, it will give us some recommendations for future design and delivery. But we are thoroughly supportive of the incredible work that's happened to date in this scope for RNs and are intending to strengthen and support more access to RN prescribing in community health. It's like the gateway to RN prescribing on the different more advanced layers than this one. And the final point on this one is around the voluntary bonding scheme. So we have opened up the applications for voluntary bonding, and it's important to note that both newly qualified nurse practitioners and graduate registered nurses are eligible for the voluntary bonding scheme. And so the applications are open for a month, and so if you have either of those types of category nurses in your employment, there is opportunity for them to benefit from the voluntary bonding scheme that is being supported by HNZ. Yeah, and I think that's probably it from our end, Liz. The next slide, we can pass on to Agustilia.
That was really, really useful information from an employer point of view, and I'm sure everyone will find that too. It's really good to, look at the initiatives that have been put into place. That's going to help a lot. So I'm just going to talk about initiatives that we have put into place from Heritage Lifecare. And these are initiatives that have come on quite gradually at the start of the year, but we've really gained momentum, and we've been able to employ a lot of graduate RNs into Heritage Lifecare. And so I'm just going to talk to you a little bit about the experience, what supports have been put into place, and how our graduate RNs feel at the moment. Next slide, thank you. So to start off with, we look at engagement. So before the graduate RN joins us or even comes in for an interview or things like that, we get them to come in a very informal manner so that they can meet up with the managers, they can meet up with the teams on the floor, and also look at the physical framework of, the way the facility is set up, just to give them a little bit of an idea of what they're coming into. And we've always had good feedback about that. It really helps because it can be quite daunting for them with their first experience of employment. So that is something we've put into place. The second thing is inductions. We've come up with a really detailed induction, which actually goes on over 3 months. Now, when I say induction or orientation, it doesn't mean that the RN is not sharing a clinical workload during that time, but it's just paced out so that things like, system management, the patient system management, the personnel, the way the organization runs, we give them time to just transition into it. So it is quite a detailed induction, and this is something that has really helped them. They say that they've really felt a sense of belonging, and they feel quite important. I think that's really good, and that actually gives them motivation to work to their full potential. So that has worked really well with our graduate RNs. The next thing was about connections. So my role within the organization as the L&D clinical manager is a new role that was commenced about 2 years ago when I joined. And it has been really useful just having someone to go to for the graduate RNs, and also to have those regular education sessions. So we don't have an education plan as such. We do have mandatory annual education plan structures in place, but on an ad hoc basis, I invite them to online sessions. And so I get to know them a bit better because I am actually in support office and I don't get to see them face to face, but meeting them regularly really helps develop those relationships. And so that's really helped as well. The other thing is about networks. When I ask them to join my sessions, they actually meet as a group and they get to know each other. And so it doesn't just stop there. They connect with each other, and it's almost like they form their own support system, and I'm not needed I don't have to spend as much time as I would have, because they are talking to each other and supporting each other through the process. The next was about buddying. So we do have, again, it's not about it's not about following an RN. When I talk about buddy, it means that for the first 2 weeks, when they start with us, they are actually following an RN and just getting used to the routines, getting used to their team, and all of that. But they start with a clinical sharing, clinical workload, but they still have someone that they can go to in the first 12 months. So it's almost like a designated RN who can help them with, it may just be queries, it may be things that they've come across and they just need clarification for. So it's not doubling up on the roster or anything like that. And the last is leadership. So our site leaders have had sessions just to explain what graduate RNs are expected to do, because there's always been this I may say barrier that managers sometimes think that a lot of support needs to be put in. But just with what we've done so far and the things put in, the site leaders are now feeling quite confident. And so a little bit of support for the site leaders is also really important, just so that they can understand that the support is no different to any other RN that would join us. It's just that we from support office are still there to support them with, documentation or anything like that. So those are some of the things that have been put into place. Next slide, please. The next slide talks about, that's okay. The next slide is really just a short slide about some of the feedback that we've got from our graduate RNs, and it just reflects on how they've developed their confidence and how they are now thinking about aged care's career that they would really want to continue with. So that feels like a success for us, and we still have a lot of work to do, but these are the comments that have come through. They say that their role has developed their leadership skills from delegating to caregivers and enrolled nurses to coordinating practical assessments. I know we've moved away from directing and delegating to enrolled nurses, but this is something that they've said, is that it really helps them coordinate practical assessments as well. It's just building confidence in themselves. The experience has helped me support our team in providing the best possible care. And this is about shift leadership and how they feel like they've been able to get their team to work alongside them to deliver the best possible care. The support from their colleagues, they said, has been really good, particularly from their managers. And this is a really important point, actually, because we do have regular checkups. So the managers will have informal chats with them on a 6-week, 3-month, and then a 12-month basis. And so these regular check-ins help to assess if they're going okay, but also to put in any support that we need to if they are struggling. We haven't had to do that a lot, so we're feeling quite confident with the graduate RNs that we've taken on board. The next slide. So yeah, just to summarize, I've spoken about this already, but just to summarize, so it is a very robust orientation. There is no there are no gaps there. We do ask that the completed induction document is cited so that we are very confident that our graduate RNs have gone through the process. Regular feedback opportunities, not just with the managers, but with myself as well. And professional development is quite informal in the sense we do have our monthly annual education plan topics that they need to do, but they also have additional topics if needed on a case-to-case basis. So that's just a summary of what we do. And I think that's it, actually. I'll put it back to you, Bex, to continue with.
Thank you so much. Just while I've got you, we touched on the funding at the beginning of the call, and you also touched on the fact that you've taken a lot of graduates across the country. Would you mind just quickly touching on how that process has been for you and how those graduates have, made a difference in your team?
Sure, I can do that. So with when we started at the start of the year, actually, we had about 3 graduates that we took on at the start of the year. So that was February. And we hadn't taken a lot of new graduate RNs before. But because I had just started the role, what we were doing is taking it slow and getting some feedback from the graduate RNs that we had already so that we could build on our processes and make sure that the supports were in place. And I think it's word of mouth, I would say that, because communities are quite close and we've got sites all over the country. So we've got 42 sites right through the North and the South Island. And I think by word of mouth, I would say we've got really good connections with the polytechs as well. And we were getting more and more inquiries about graduate RNs joining us. And so we were slowly able to get that process in place and make sure that we were not overdoing it. We were doing it gradually so that we were supporting them. And we've now got nearly 11 new graduates, graduate RNs. And I think that number will increase. So it's been a really good experience.
Thank you. I appreciate it. Okay, so the last little slide we've got here is, I touched earlier that my job is to connect the graduates. So whether you're looking for a graduate RN now or into the new year, we want to help graduates connect with you. So we've put a couple of supports in place. One of them, which hopefully you can still see my slides, is the graduate RN web page. So we've developed a graduate web page within the careers environment, where it's essentially a hub for graduates, linking them to information, opportunities, supporting them gaining their employment, and really importantly, what we've done is created a central link to graduate vacancies. So that leads me into you can also advertise your vacancies for free on the careers website. I've got a little bundle of things to send across to Rebecca after this, which will include the instructions on how you can list your vacancies for free. It is just graduate RN vacancies, so can't list all those vacancies. I'm afraid it is just the graduate RN ones so that we can direct them to the right place and help connect you. So with that being said, we've just got one last speaker, Nadine Grey, our chief nurse. Over to you, Nadine.
Thanks very much, Bex, and kia ora koutou. Firstly, I just want to thank you all for the time to join the webinar and hear about the progress around supported first year of practice. And yeah, just really want to thank you for your time. Just to reiterate what's been shared today, our graduate RNs offer so much to the New Zealand health system, and I guess we're going to stretch ourselves in our thinking and our approach to from a strength-based approach to bring them into the workforce, and just know that we are huge champions of nurses beginning their careers in communities and within aged care. My own personal experience of beginning my career in aged care certainly set me up well, and so we're here to support you, and at any time, just please reach out. I think just to some of those examples that have been shared around, from not many graduates to 11, and I just think how far nursing has come and what we could actually grow in our communities, particularly for older persons. It has no boundaries, particularly with prescribing in all of our scopes. So thank you again, and please do reach out. Nō reira, tēnā koutou katoa.